Hello, everyone, and good morning or good evening, depending on where you are. We welcome you once again to the RO webinar. And as promised, we have a fantastic lineup of speakers, starting with an international speaker, Dr. Sabyasachi Sen, sir, followed by Dr. Sunil Gupta, sir, who's our treasurer of RO and is also the RSSDI president-elect. Uh, and we have Dr. Rucha Mehta, who's on the executive board of RO. And all three are fantastic speakers. And we are really hoping to learn a lot today. So without wasting any more time, let me hand it over to Dr. Banshi sir as well as to Dr. Sunil Gupta sir to share a few opening thoughts, and then we can introduce the speaker. Dr. Sunil Gupta sir, please.
Okay, yeah. So, good morning, everyone. And on behalf of RO, I welcome you all for this wonderful clinical webinar. I'll say is more towards getting some strong messages across global sharing and putting ourselves into Indian perspective. So this particular webinar has been started by RO very recently through the efforts from Purvi. So congratulations, Purvi, for this. And of course, Bansi Bhai is always there to guide us. And of course, we have Dr. Makkar and Dr. Narvaria. All of them are really working hard. And now we have forthcoming AOCO. So most of the listeners who are attending this meeting, hopefully we are all meeting in December. And this very much this month at Delhi for AOCO. And we have wonderful topics related to hypertriglyceridemia. Again, a topic which is very close to not only Rucha's heart, but also my heart too. Rucha, I love this topic, and we have done some original work on postprandial hypertriglyceridemia. And that's again another food for thought for most of the researchers. So we are going to have a wonderful international speaker from all the way from US. Dr. Sen, I welcome you on behalf of RO, and we have Rucha who's going to talk on the clinical or the case-based discussion kind of picture, and then I'll be giving a very brief outline of what recent thought process we have about obesity as per as the Indian guidelines and Indian needs are concerned. With this, I welcome you once again on behalf of RO. Thank you very much for inviting me here.
Thank you so much, sir. And yes, you're right. It was Dr. Banshi sir who encouraged us to have these webinars. I'll just invite him to share a few thoughts.
Thank you, Purvi. First of all, thanks, Sebi, Sabyasachi Sen. So happy that I have here on this online webinar. A close friend of mine, and many of us know him since years. He's always available for us for anything. Now, diabetes move around obesity. And we have our Indian obesity meeting, which is Aiaaro with AOCO, which is Asia Oceania big meeting, where we will be having more than 1,000 doctors, and probably all the South Asian countries and Western Pacific countries will join. This meeting we are going to have in the month of December only, third week. It is in Delhi. We all are very excited to welcome you all. I'm sure many of you will be available there during AOCO meeting face to face. For those who will not able to join, I'm sure we will do this year many webinar, many meetings, because I already lined up with say one more meeting with Obesity Society with Diabetes India. So I'm sure many of you will able to join. But it is always, very, very important and to know more about obesity. It's really very difficult topic. Even we know many things, but still to convince the person with obesity to lose weight, to maintain it, and to start even the newer therapy. It's real difficult. So we all are in the learning phase. And I'm sure this webinar, which is organized primarily by Purvi and team of Aiaaro, will be very useful for all of you. Thank you, Purvi, for this wonderful opportunity to me. And me and Sunil are there, and we will have more discussion during after the talk. Over to Purvi for inviting both our speakers. Thank you, Rucha. Thank you, sir, once again.
Fantastic. Thank you so much. And let's get straight to the webinar. So we are very happy, Dr. Sabyasachi Sen, that you have agreed to be with us today. To all of you who don't know him, he is a senior endocrinologist, lipidologist, and obesity medicine specialist, and chief of endocrinology, diabetes, and metabolism at Veterans Affairs Medical Center, Washington, D.C. He's also the professor in the Department of Medicine and Endocrinology and professor of biochemistry and molecular medicine at the George Washington University in Washington, D.C., professor of uniform services, University of the Health Sciences at Bethesda. His basic research interest has involved around behavior, survival, and differentiation of human adult stem cells in hyperglycemia. His current research projects include the effect of exercise, incretins and glucose transport inhibitors, and also artificial sweeteners on endothelial function and endothelial progenitor cells in patients with prediabetes and diabetes. The lab is also studying the use of genetically modified EPCs or the endothelial progenitor cells and mesenchymal stromal cells in mouse models of diabetes complications such as cardiovascular disease, chronic kidney disease, and so on. So thus he has a multifaceted career and very relevant to our intention today of enhancing our understanding of obesity and everything that is around it. So without much ado, we invite him to speak on hypertriglyceridemia in diabetes and obesity.
Thank you, Purvi. Let me try to share my slides. Okay. Can you guys see it? Awesome. So
Yes.
thank you so
Yes, we
much.
can.
Thank you so much for having me. Over the years, yes, as Banshi said, I've got to know many of you. Banshi is a close friend of mine who introduced me to the Indian diaspora of Indian endocrinologists. And subsequently, I got to know a lot of you and I've become very close friends of all of you. I wish we could do some research together, either epidemiological or basic or translational. So please reach out to me if any of you have any ideas. So this is essentially should be a discussion forum. So let me go through the main proposal today, which is hypertriglyceridemia as the crux of or the center of diabetes and management in of diagnosis and management in obesity and diabetes. So these are my current funders. So the link between high triglyceride and obesity is fairly well established in the sense that we all know that the causes of raised triglyceride are obesity, diabetes, metabolic disorders, and lack of physical activity. In fact, I put the lack of physical activity the lowest out there because I think there is a inherent component which promotes one towards obesity and uncontrolled diabetes. And in fact, obesity would usually precede type 2 diabetes in most cases. I wouldn't say in all cases, but in most cases. So there is a close link between so-called adipose tissue and hyperglycemia at the crux of it. So as you can see on the right-hand side, we have two modalities. One is in black box, which is the normal physiology, and in the red box, which is the abnormal physiology, where you have inflamed adipose tissue, secondary to maybe multiple causes. Usually the causative factors are increased reactive oxygen species. which inflames the adipose tissue, secondary to what you all know and probably what you all treat is sleep apnea being one of the causes, which actually increases the triglyceride and cholesterol uptake in the adipose tissue and would also reduce the cholesterol efflux as well. So essentially, you're holding on to the triglyceride in the adipose tissue way longer than you should. So it almost becomes a constant feeder situation, which subsequently leads to ABCA downregulation. And if you remember your biochemistry days, ABCA is one of the key proteins that assimilates LDL inside the cell. That also subsequently reduces HDL. And as you know, low HDL and high triglyceride is one of the two major factors of metabolic syndrome, which progresses to prediabetes and diabetes. So I believe early detection, and most endocrinologists would now believe that early detection of high triglyceride and low HDL is crucial. We of course need to see, and that may not be always be associated with abnormal LDL. So your first clue in your patient that you see for any other reason, let's say you're seeing them for non-obesity or diabetes causes in primary care setting, high triglyceride essentially is your key to future metabolic disorders. Of course, one needs to exclude secondary causes such as excess alcohol intake, which is usually more than 1 or 2 drinks a day, nephrotic syndrome, hypothyroidism, and check for obvious signs of adiposity. Liver enzymes is another marker in this whole context. And check for dysglycemia, fasting hyperglycemia. And another clue, which you would probably think of, which I didn't put in here because it's somewhat controversial, is low platelets. Oftentimes you would see low platelets associated, and that's one of the factors that goes into FIB4 scoring for MASLD. So we are not going to talk about that today. However, all these actually leads to increased visceral adiposity and increased incidence of MASLD and other disorders from obesity. So objective of my talk, I've put my talk around a scenario when you have high triglyceride more than, let's say, 1,000. That's just a number. It could be 885, it could be 555, whatever. So anything above 450 or anything above 500, you need to look into what are the causes of it. So that could be a multifactorial, familial, lipodystrophy, and dysbeta-lipoproteinemia primarily. So these are the four main causes. I'm going to briefly go through it and very quickly go through the newer therapies of triglyceride lowering. I'm sure you are well aware of the current treatment regimens. I'm just going to introduce some newer therapies today. So let's talk about the two main causes up there, which is multifactorial versus familial. How do you differentiate this? So obviously the multifactorial is way more common. It's about 95% incidence of high triglyceride. Uncommon, of course, are the other three. And if you look at the genetic architecture of hypertriglyceridemia more than 885, this is essentially from Journal of Clinical Lipidology, which is essentially the official journal of National Lipid Association in the United States, which I'm a fellow of, and I believe their guidelines are pretty broad, has a broad consensus. So here you see that you have a homozygous familial hyperchylomicronemia syndrome or hypertriglyceridemia syndrome at the very left. And then you have the multifactorial, which is essentially heterozygous or other genetic causes, and a portion of it is genetically undefined yet. I wouldn't say it's not there, it's just undefined. When to suspect familial chylomicronemia syndrome? Well, here is a table on which based is the North American score or NAFCS score. And as you can imagine, the familial would be more in pediatric age group compared to adult age group, which would have multifactorial. In multifactorial, it could be fluctuating. In familial, it usually stays extremely high. Definitely, it's difficult to bring them lower than 800. Triglyceride to total cholesterol ratio is more than 8 in familial, is usually 5 and sometimes even drops lower. ApoB, and you would hear me talk about ApoB, and somebody, last time I gave a talk in India, they said, oh, ApoB is not available. That's actually not true. I've actually looked at the laboratories across India, and you do have ApoB. It's actually a very good marker in the sense that if you're trying to figure out if your high triglyceride is causing high CVD. So as ApoB attaches to every atherogenic particle, it's actually important item to look at and pick up early on. So it would be low or normal in FCS because it's purely triglyceride disease, whereas in multifactorial, which is usually normal or high, the treatment is more in response to the triglyceride levels in MCS, whereas it's refractory in FCS. Pancreatitis incidence is obviously way higher in FCS than in MS, MCS, or multifactorial. But once you have pancreatitis, 50% of your pancreatic cells are dead. So you need to avoid that situation at all costs. CVD risk is definitely higher in MCS than FCS. So this is the national FCS scoring component, which includes age, BMI, history of pancreatitis, and others such as recurrent abdominal pain, which is essentially a missed the pancreatitis episode. Laboratory values again talks about apolipoprotein B, um, triglyceride and total cholesterol ratio, and the triglyceride consistently above 880. So keep these in mind. So for FCS, certain genetic scenarios have already been identified. The top one being lipoprotein lipase, which is at the very top, which is about 60 to 80% of all the cases. ApoC2 inhibition can also lead to it because ApoC2 is supposed to be the good guy. C3 is the bad guy, just as far as the lipidology is concerned. And rest, I find it difficult to remember, but at least try to have this list available if you are into FCS and genetic testing. When do you suspect lipodystrophy syndromes? That's the other conundrum. So lipodystrophy is not that uncommon. I think we fail to pick it up. Then in most cases, it's an early scenario of insulin resistance, premature diabetes, hypertriglyceridemia, and low HDL, which is very similar to other scenarios, but you have to look at the physical presence of the patient, which is you have a more preserved fat in the upper portion of the body. They may be very muscular looking and very thin arms and thin legs. This is essentially a picture from Abhimanyu Garg's New England Journal of Medicine paper. So when you suspect the other cause, which is dysbeta-lipoproteinemia in lipidology and in endocrine boards in the United States, this always comes up. This is rare, but one should not miss in this day and age when ApoE screening is very prevalent. Remember, ApoE actually, apolipoprotein E goes into different diseases. E4 is associated with Alzheimer's and gets tested quite extensively these days in geriatric population. E2 leads to your dysbeta-lipoproteinemia. E3 is essentially your normal phenotype. So if you have a Palmer's xanthoma that's being shown here in the picture, and you have high triglyceride, do think of dysbeta-lipoproteinemia, which usually presents as a mixed hyperlipidemia, which means total cholesterol and triglyceride could be even 1:1. So I very briefly alluded to what's the connection between triglyceride and CVD. Well, there's several data that shows there's a connection, but I don't want you to focus here on any of the papers. However, remember that there is no triglyceride really in any atherosclerotic plaque. Till date, nobody has actually shown that there is triacylglycerol in the atherosclerotic plaque. So how does it actually associate with CVD? It associates with CVD secondary to the inflammation that it causes and due to the remnant cholesterol that it forms after the heavy triglyceride in the system, leading to endothelial dysfunction, which, as you all know, is probably the initial steps of insulin resistance and metabolic dysfunction. So let me summarize this aspect before we go on to the treatment. That severe hypertriglyceridemia is mostly multifactorial. There is the genetic component, of course. You need to be aware of some of the causative genes such as LPL and disorder, which is the commonest, the other being the ApoC2 presence or ApoC2 mutation, meaning for loss of function. The link between triglyceride and CVD is not very direct, but via the remnant cholesterol. So I would advocate to measure non-HDL cholesterol, which would take into account all the atherogenic particles coming from the triglyceride pool. Try to look into remnant cholesterol, which is essentially non-HDL cholesterol minus LDL. That would give you the value. And ApoB is to ApoA1 ratio, which should always be less than 0.76, which is the first step of high CVD risk. Going on to the treatments in the last couple of minutes, you know that there is insulin, which we actually do use in triglyceride emergencies. The way insulin works is it increases lipoprotein lipase. The other ones are PPAR alpha agonists, such as fibrates, omega-3 fatty acids, which lowers the triglyceride by only about 30 to 40% at max. Usually these agents, that's about fibrates, omega-3 would reduce about 20%. Remember, if you're using omega-3 fatty acids, try to use the EPA component, which in the United States is known as VASEPA, which is, and there's essentially two omega-3s that we use, EPA and DHA. I took out that slide, that's why I'm talking over it. So try to use EPA, which has shown CVD risk reduction as opposed to DHA component or the combination. So despite the TG lowering from these agents, all the drugs till date falls short of triglyceride lowering effectively. In fact, there's almost no benefit if you have a FCS patient. That patient is almost doomed to get a pancreatitis. So this is essentially, as we talked about before, the levels of triglyceride. There's increased chylomicrons when there's a very disastrous situation where there's a lot of white chylomicronemia that you can see in the circulation, but you should not get into that situation. So newer therapies, the main one that I'm going to focus today is ApoC3 inhibitors. So ApoC2 is a good guy, as I mentioned before. C3 is a bad guy, which inhibits lipoprotein lipase. So we are essentially trying to inhibit apolipoprotein C3 function or its activity on lipoprotein lipase so that the lipoprotein lipase is preserved. That's one gene and one cause which we have clearly identified as the reason for hypertriglyceridemia, that is low lipoprotein lipase. And effectively, we have made drugs that would inhibit ApoC3. So ApoC3 inhibition, it would, as I said, increase lipoprotein lipase and would inhibit hepatic lipase and would increase the clearance of triglyceride-rich lipoproteins. I think I've explained the rationale. There is two main ways that you can inhibit ApoC3. One is an antisense oligonucleotide called ASO. The other one is siRNA. It's just two ways to inhibit that gene function and that protein from the gene function. Remember, if you have a anti-sense oligonucleotide, it would always end in SEN, like my last name. All ASOs would end in SEN. Similarly, all siRNAs would end in siRAN. For example, I'm sure you use inclisiran, that is a siRNA for PCSK9, right? So these are the two drugs, that olezarsen and polizarsiran, that are right now approved or about to be approved. This is the data for olezarsen, which shows with about 71% reduction in patients with a previous history of pancreatitis who had a mean triglyceride of 2,600, balanced trial. The other one is siRNA, polizarsiran. It's almost there to be approved by FDA, and about 50% reduction in triglycerides with a baseline of about 2,000. Lower triglyceride, lower lowering, of course. Efficacy, in general, even if you have triglycerides in the level of thousands, your olezarsen reduction would be about 60%, polizarsen about 80%, sustained effect. So it's very effective in familial causes. Safety issues, like any biologics, you would have an injection site reaction, no significant thrombocytopenia, which is great. Mild LDL elevation, which is almost all triglyceride lowering agents would do so. We have not figured out why that's the case, but it's very mild. Don't worry about it. And it's usually fluffy LDL rather than small, dense LDL. And occasional hyperglycemia. So olezarsen was approved in December 2024, came into the market in January 2020 this year. Polizarsen is almost about to get approved as well. Other targets is angiolipoprotein L3. This is definitely less effective than ApoC3 inhibition, but I thought I should mention it anyway. It also has endothelial lipase inhibition effect. It is a common drug that's currently approved for LDL lowering called Evkeeza. As a trade name in the United States, it's called evolocumab. It's a mononuclear antibody to angiolipoprotein L3. So in conclusion, ApoC3 inhibition does decrease triglyceride in almost all cases, at least by 50%. Olezarsen is a ASO and approved for FCS. You can also use it for MCS. And these new powerful triglyceride lowering agents does have the potential to decrease the risk of pancreatitis, which should be your main goal when treating patients at a bout of multiple bouts of 500, 600. These patients, by and large, would have LDL lowering. Some of these patients do have heterozygous LDL defect, LPL defect. So don't just tell them that, oh, you drink too much alcohol, you eat too much fat. Let's face it, we all do. So give them some slack, try to look at the cause of them and treat them accordingly. And of course, lifestyle and exercise is important as you are talking to them about LPL targeted treatments. And thank you for listening to me.
That was a
Happy to take any questions.
fantastic talk. Thank you. Thank you, Dr. Sen. I think on a busy Thursday morning, you still were here and you really simplified the topic so well. I just cannot believe you covered so much in 15 to 20 minutes. We are very lucky today. We have almost a whole house with AOCO coming up. Thank you, Dr. Makkar sir, also for joining, and our senior members, Dr. Sarita Bajaj madam, Dr. Bikash Bhattacharya sir. Very glad to see you all. And Dr. Makkar sir, do we have questions for Dr. Sabi?
I'm sure some of you must have one or two questions.
So, yeah, Saya. So, we have a lot of experience. If I can initiate the conversation, we are using inclisiran for LDL lowering, but I don't think we have started initiating it as much as for triglyceride lowering. So, can you tell us practically, like in your practice, when are you using it? Is it only for familial chylomicronemia, or also more commonly we'll see patients, with our usual garden variety of metabolic syndrome, diabetes, and we do see high triglycerides in these patient populations. So when should we consider using it? Does it have to be a mixed lipid disorder, like, with a high LDL, or can you use it purely for a high triglyceride? And, if you can guide us on that.
Right. So LDL lowering, yes, you need a PCSK9 inhibition. What I was trying to impact on was triglyceride lowering through lipoprotein lipase activation or ApoC3 inhibition. So these are two pathways, and of course, there's a crosstalk between the two pathways. PCSK9 inhibitors, for example, you have MABs, like evolocumab, which is a mononuclear antibody against PCSK9. Then you have siRNA, which is inclisiran, right?
Saran.
So both of these two agents do have about 20% L triglyceride lowering effect, which I believe is not enough. In fact, fibrates does very better job than that. So if you're trying to lower triglyceride in a case of mixed hypertriglyceridemia, where it's almost synonymous to a multifactorial chylomicronemia syndrome, we need to treat both the paths, meaning LDL path and triglyceride path, right? And for two different reasons. LDL, or in other words, total non-HDL cholesterol needs to be reduced because of the high CVD risk. The triglyceride lowering is primarily to prevent a development of pancreatitis or even occult pancreatitis. So these are two separate issues. We mixed hypertriglyceridemia even today. You should start with a statin, add a fibrate to it, and omega-3. Now, if you have a consistently high non-HDL cholesterol, and I'm not going to talk about LDL or non-HDL cholesterol because the other components get mixed, then even on statin, or a better marker would be ApoB, which is significantly high, then you should definitely consider a PCSK9, which would have an effect on CVD lowering. And if that patient also has a concomitant high triglyceride, then a ASO and siRNA, for example, olezarsen or polisiran. So that's essentially the tree or the stepwise management plan in these
Great,
patients.
thank you. And it's needless to mention that it's great to have you here on our forum. So, Sabia and I go way back as working as endocrine fellows together. So it's wonderful to see him here on this platform. And I'll hand it back to Purvi. I just wanted to say that, of course.
Thank you. Thanks, Rucha.
Great. So I think I'd request you to elaborate a little more on ApoA as little a as a marker, which we do not follow very regularly. We don't screen for that, but your thoughts on that, especially in the Asian Indian population.
Right. So the apolipoprotein little a, as we call it, is a heterodimer. I know these words sound big, but essentially all it is a combination of two molecules, which is ApoA1 and ApoB, right? The two molecules, when they come together, that's when they form a heterodimer, which forms a lipoprotein little a. We didn't have anything else to call it at that time in NIH. So the consensus was lipoprotein little a. But why that is dangerous is because that molecule has almost 95 to 99% homology with plasminogen activated receptor molecule, which means if it sits on a plasminogen activated receptor, it can trigger a clotting cascade on its own. That's the main worry, which means somebody who has a high chance of these two forming a heterodimer and that's genetically, or that's an autosomal dominant disease, right? And that gene is very common in Southeast Asians, unfortunately. So the clotting cascade, as you know, there could be microthrombi in the brain, microthrombi in the heart, microthrombi in the liver, microthrombi in the kidneys. Some of this, why I'm talking about all the organs is because, for example, CKD patients have been shown to have high lipoprotein little a. In fact, GFR lowering seems to be congruous with the lipoprotein little a values. The lipoprotein little a is hard to treat because we don't have any targeted therapies for it. The best we have right now, and there are newer drugs coming out, is essentially PCSK9 inhibition, which lowers the lipoprotein little by about 30%, simply by increasing the renal clearance of these molecules, right? And there are targeted therapies coming in, but I think if we, at least every patient, every person that comes to our clinic should have at least one time lipoprotein little checked, because it's a genetic disorder. It can pass on to your kids and so on, and of course the siblings unknowingly. So somebody passing away with very high levels of lipoprotein needs to know that that risk is not only for him but also his other family member. It is an autosomal dominant disease, so everybody needs to get it checked. And if that's the case, that's another reason why you should try to use PCSK9 sooner than later in those patients to lower the CVD. The risk of apolipoprotein has not been directly correlated to CVD, but every case of high lipoprotein, like critically high, has been shown to increase the mortality and morbidity associated with CVD. So it needs to be treated. It needs to be known that the patient has high lipoprotein. There are two ways to looking at it: milligram percent per deciliter or milligram percent or nanomoles. So make sure what you're looking at, the laboratory that you're getting the result from, actually tells you whether it's nanomoles or milligram percent. Hope that helped.
Thank you. That was really fantastic. That was like a mini masterclass itself. So thank you. And I don't see any further questions in the chat box, but we will send them to you. I know you also had a time crunch, but we would love if you can be here till the end of the webinar, but please feel free. We all thank you very much. And I'll invite Dr. Makkar sir, who's our Secretary General of Aiaaro and also the organizing chairperson for AOCO. I'll just invite him to share his thoughts.
Muted.
So we are not able to hear you. Maybe just disconnecting the earphones may.
What
No,
happened? Why
sir.
so silent, everyone?
No, we are not able to hear you, sir. So, sir, while you fix the audio, sir, his audio connection is poor. Uh, I will request Dr. Sarita Bajaj ma'am also to share her thoughts.
I think regarding the current topic that we've just heard, I think bringing out lipoprotein little a as a very, very important test, I think that is something that we are not doing on a regular basis. And quite often we just get a lipid profile done. Rather, I mean, they're very complete lipid profile, extended lipid profile. But I think the take home message to get at least once a lipoprotein A done And we know it is established from the age of 2 years onwards. So it can be done at any time. But I think I really appreciate that message. And of course, all the newer molecules that have been discussed, I think Rucha also mentioned that they're already using a particular molecule. I think I've really learned from this topic. Thank you very much.
Thank you, ma'am.
Thank you.
We can move on to the next speaker, our very esteemed Dr.
Dr. Braj could, I feel now can speak. I feel his speaker must be working now. Dr. Braj Makkar sir, can you just try your audio again? I feel now he'll be able to. You're still muted. Can you just unmute yourself? Yeah. No, it's still the same. Okay. We go ahead. Purvi, over to you.
Ma'am, please welcome our next speaker.
It's a pleasure to welcome Dr. Sunil Gupta, who's one of the most charming and wonderful persons I know of. He's currently the National Treasurer of Aiaaro and National President of DIPSI, President-elect of RSSTI, and he has many qualifications to his credit apart from MD FACE, FRCP, London, Glasgow, Edinburgh, FACP, FICP, FIAMS, FIACM, FTI, and FRSSTI as well. So it's a great pleasure to welcome him. And he will be talking to us today on obesity in Asian Indians, implications of new obesity guidelines. Over to you, Sunil.
Thank you, madam. And thank you very much, Purvi, Dr. Bansi Bhai, Dr. Makkar, and the whole team of Aro. It's always a pleasure to be a part of such meeting where we really learn from each other. And the earlier talk was really too good to again revise the importance of hypertriglyceridemia after a long, long time. Now, my topic is very brief and it's going to be very, very clinical. Uh, Obesity in Asian Indian implications of newer obesity guidelines. So I'm just going to speak for next maybe 13-14 minutes on this topic. Thank you very much, everyone, for invitation. There is no conflict of interest for this particular session. We'll have introduction, global guidelines, one or two slides, and then we have the Indian phenotype, which most of you are already aware of, that why we are different from other races or other people or Western people like Caucasians. And how do we behave differently from them, and why do we need our own guidelines for management of for the classification and management of obesity for our country? And what is the proposed what are the proposed guidelines we have very recently in July in this year itself, maybe a month or 2 months back, and the final message. So obesity, everyone knows, a complex chronic relapsing disease characterized by excessive adipose tissue accumulation that impairs health. It is a key driver of metabolic disorders, which include type 2DM, hypertension, dyslipidemia, non-alcoholic fatty liver disease or MASLD or cardiovascular disease. Beyond metabolic implication, obesity associated with increased risk of cancers, osteoarthritis, obstructive sleep apnea, or psychological distress. Pathophysiology involves a dynamic interplay between the genetic, neurohormonal, behavioral, and environmental factors, with central role of insulin resistance, inflammation, and gut-brain axis dysregulation. So I'm not going to go too much into obesity, but we'll be talking directly
I think Sir will have to join in again. Dr. Makar sir, is your tech issue sorted? Then
Hello.
yes, we can hear you now, sir. So we heard you. We could hear you.
Okay. So I thought Sunil is presenting. He's got disconnected.
I know. I think he would reconnect, but until then, if you would like to share.
I think it was a very interesting presentation. I joined actually a little late, so I missed the early part, but I think it is very important. Only only challenge is that how far we can use the PCSK9 uh, like drugs in Indian setting. That's always a big challenge. And I also wanted to, ask him about the dual PPAR alpha gamma that we have in India, which they're not using. But it was interesting presentation. Sunil has joined back.
Yes, sir.
But it's not audible.
I'll just take another minute for
Oh, yeah. Okay.
Sure, sir.
for the yeah.
So till the internet stabilizes, in case you feel that
No, it's okay. I feel I'm already on. Just
Okay.
we'll take 30 seconds and it will be should.
Yes, sir.
I don't know what happened wrong with this. Suddenly it just
It
stopped.
just froze. I know. No, I was going to suggest you could keep the video off if you feel that it's
Yeah, I'll do that. Now you can see the slides, right?
Yes.
I'll keep my video off so it will be correct. So hopefully I'm audible and I'll go through the.
Yes, sir.
So introduce the topic. Obesity is prevalent. I'm not going to go again in detail of it, but we need to now treat obesity as a disease and make people realize that we need to address this more aggressively than ever. The situation in India is quite bad as compared to many other countries. So rising obesity across the region, it increasing not only in Indian cities but also towns and rural areas. And it is associated with all those comorbidities which I told you. Pandemic of COVID has been shown to have again a worsening obesity because of because everyone was at home and because of the sedentary life. And we need to have updated guidelines when it comes to we as a different phenotype versus anyone else. And this is again a epidemiological data from various studies, like we have ICMR study which says almost 30% of our population above 18 years of age have more than 25 BMI. If I go for more than 23, it will be higher. And especially 40% of them, they may have even the central obesity. And the other data from NFHS again has said that more than 23, almost 44% of men and 41% of women, they have obesity. Similarly, we have childhood obesity, which is also growing. And importantly, this trend is more of concern because it increases the risk of cardiometabolic diseases overall, from the childhood or from the adolescent to the adults. So global guidelines, if we just say, most of the global guidelines have classified it on the basis of BMI, where they have said that up to 25 BMI is normal, 25 to 30 BMI is overweight. Then obesity has been divided into class 1 and class 2. So 30 to 35, 34.9, that's 35 is class 1, and 35 to 40 is class 2. And extremely obese is more than 40. And globally, it has been accepted by WHO and many other organizations across, and being followed by them. Now, there's also a classification. If it's less than 18.5, we call it as underweight. 18.5 to 25, they say normal. And then you have overweight and then obesity 1, 2, and obesity even 3. So these guidelines have also said that those who have BMI of more than 27, they may go for the medication after the proper trial of the medical nutrition therapy and lifestyle modification. And if you have BMI of more than 30, and as well as if you have more than 27 with some comorbidities, they can go for medication. And eligible for surgery is more than 30 BMI when it comes to recommendation. But we know that we Indian have different phenotype. And this is, we have a central obesity or abdominal obesity, which is quite prevalent. This is the obesity parameter where they actually taken waist circumference of more than 80 centimeters in women and more than 94 centimeters in men, and BMI at more than 25. So women, we have almost 40% of the women, they have obesity. Men, it seems to be little less, but this is an important paper which was published in Lancet in 2023. More important to that is, up till now, we are talking about only intra-abdominal visceral obesity. But now it has also coming into the literature that it is not only the intra-abdominal visceral fat which is atherogenic, but also you have subcutaneous fat, which is again divided into two: the superficial subcutaneous abdominal fat and the deep subcutaneous abdominal fat. And this again is equally bad as that of the visceral fat. To some of the papers, they say this fat is more important than the visceral fat, and which again is culprit for not only MASLD or MASH, but also for the pancreatic fat deposition across, and which ultimately leads to decrease in the insulin secretion, decrease in insulin response to the glucose or drugs, and causes diabetes. So it is important to understand that abdominal obesity, which includes visceral fat, intra-abdominal, as well as the subcutaneous superficial and deep fat, both of them need to be addressed in defining obesity, so that we can really prevent the cardiometabolic diseases and the complications of obesity in future. Now, if you compare the adiposity between the South Asian or Asian Indians versus the Caucasians, another ethnic group, then your total body fat is higher in this group. Total abdominal fat is higher even at the same BMI, and we have YY paradox with us, which is again an example which every one of you know are aware of. Subcutaneous or truncal or abdominal adipose tissue is higher, but not seen in all the studies. But you have a meta-analysis suggests is very strong that most of the studies, they have just checked the abdominal visceral one. So they say that's strong. The thigh subcutaneous adipose tissue is increased, and the deep subcutaneous abdominal adipose tissue is again higher, but we need to have from more data as far as its heterogeneity is concerned. So intra-abdominal adipose tissue is higher enough, and we have enough studies on those lines, and which is atherogenic. Hepatic fat is again higher, strongly concluded in the meta-analysis. Intramuscular fat is again higher, epicardial fat higher, pericardial fat we have conflicting result, and adipocyte size is again higher in our population versus the Caucasian or other ethnic group. So we are being called as thin fat Indian or thin fat body type, and thin fat Asian Indians appears lean with by the BMI, but has disproportionately high body fat and central obesity. Laboratory features have shown hypertriglyceridemia, low HDL, and impaired fasting glucose. Thin fat phenotype is strongly associated with the early onset of type 2 diabetes, MASLD, and premature CADs. And this phenotype is seen in urban, rural population across the socioeconomic status. It's not just it's a rich men's disease, or it's only in the royal people. It's in everywhere across. Clinical cues include the family history of diabetes, acanthosis nigricans if you have, or a visual truncal obesity despite a relative normal. So you may have normal BMI, but still you can have signs of insulin resistance seen. Visceral adipose tissue function as an active endocrine organ, secreting inflammatory adipokines and free fatty acids. Asian Indians, they accumulate visceral fat at a lower BMI. This I told you. We have imaging techniques like CT, MRI, DEXA, which can demonstrate the visceral fat, and we have shown it is higher than the Caucasian. Visceral fat has shown stronger correlation with the cardiometabolic diseases, and subcutaneous gluteofemoral fat appears to be relatively protective. And this is the YY paradox, where we have Yudkin and Yasnik with the same BMI have 9.59% of body fat here and 21% body fat in Yasnik's. So sarcopenic obesity is another challenging and newer emerging topic amongst most of us, though we are discussing about it since long, but then things have been picked up very aggressively in the last few years. India has a very high prevalence of diabetes and pre-diabetes, and with even lower BMI. Large number of patients present with HbA1c above 7%, 7% at BMI of even 23, between 23 and 25. Metabolically obese normal weight people. Again, this phenotype is also frequent. Central obesity and FLD, we told you, and traditional BMI based threshold, therefore, underestimate the cardiometabolic risk and delay the intervention in these individuals. That's why we have to have our own cutoff for BMI, as well as including the central obesity as a part of the classification. So what is actually, if you go through the global guidelines, they're all BMI centric. And WHO classification says 25 to 30 is overweight and more than 30 obese. And most of the other guidelines also have gone through the same line. We have to have our own Asia-specific BMI recommendations, as well as adding the other features. So there are pitfalls of BMI, as I told you, that BMI does not differentiate between the fat and the lean muscle mass, limiting its effectiveness in assessing the obesity-related health risk. The importance of abdominal obesity is closely linked to insulin resistance and CVDs, and we need to have our own classification with patients who are lower BMI and have associated comorbidities like diabetes, hypertension, and which is common. So why BMI alone fails to in Asian? BMI is simple ratio of the weight to height and does not measure the body fat directly. That's one part. It cannot distinguish between the lean mass and the fat mass, or between the subcutaneous and visceral depots. As a rule, BMI fails to identify this metabolically obese normal weight individuals, as well as the sarcopenic obesity, which is prevalent in India or Asian people. Within BMI of 23 to 30 range, Indian adults actually exhibit a wide range of cardiometabolic risk, and persisting with high BMI cutoff for the treatment, we might miss out many of the opportunities. So now that we have the evolution of Indian obesity cutoff. So in 2009, if you see the almost 16 years from now, Indian consensus has proposed the cutoff of BMI to be 23 from 25, and which has been accepted globally. We have also defined our own waistline as 90 centimeters for men and 80 centimeters for women. And these adjustments acknowledge the high risk of lower BMI, at even lower BMI, and that has to be now that has to be included in the newer classification. That's what is a proposal. Subsequent research has also provided robust evidence about this role of central obesity and other parameters and the risk. And clinical experience shows that many high-risk Indian patients fall into this category. So Indian guidelines, now classification for obesity. So revised guidelines says that the consensus was developed by a multidisciplinary panel, and it has now come out with stage 1 innocuous obesity and stage 2 obesity with consequences. So this has now this particular guideline has said that we are not BMI centric. So we have BMI, which is more than 23 as the entry point of this classification. And they have also considered waist, cardiometabolic comorbidities, and functional limitations in the staging. So what is this? The stage 1 or stage 1 is obesity criteria, where defined obesity as BMI more than 23 for Asian Indians without symptoms or related disease, or basically highlight early obesity stage. Stage 2 is more than 23 combined with increased waist circumference or waist to height ratio, plus some of the health complication. And the management approach, stage 1 requires early intervention. Stage 2 demands aggressive management, maybe pharmacotherapy and bariatric surgery in future. I'm not going to show you how to take waist circumference. I'll just skip this. So from BMI centric to the phenotype centric thinking. So traditional BMI, as I told you, now in this classification, if you see stage 1, you have mandatory criteria BMI more than 23. Optional measures is waist or waist circumference or the waist to height ratio or and the body fat. Required condition for stage 1 is no obesity associated limitation in the daily activity and no obesity associated comorbidity. So it's a clear case of obesity more than 23 without comorbidities, but also may have higher waist circumference. Second, obesity stage 2 is mandatory criteria more than 23 and required condition is excess, at least one of them, that is excess of waist circumference, elevated waist to height ratio. Additional requirement will be associated limitation in daily activity or the associated comorbid diseases. So stage 1, as I told you, more than 23, optional, you have waist or waist hip or all these factors, but there are no symptoms, no associated comorbidities, and just obesity or medical nutrition therapy is required. Stage 2, you have the same as BMI more than 23, but have at least one of the following, that is waist circumference or waist to height ratio or body fat, again preferable but option. Obesity has to be associated with some limitation of the due to obesity, maybe shortness of breath or palpitation or musculoskeletal symptoms of pain, joint pain or the lower limb, or you have obesity associated some illness or comorbid condition, could be diabetes, type 2 diabetes, cardiovascular disease, hypertension, obstructive sleep apnea, non-alcoholic fatty liver disease, dyslipidemia, osteoarthritis, or other health disorder, polycystic ovarian disease, infertility, and other things. So in the stage 1, you have to have lifestyle modification. Stage 2, you'll have to have lifestyle modification along with the pharmacotherapy, and it may be injectable or even surgery. And these are the symptoms which I already have alluded: respiratory shortness of breath, cardiovascular, maybe palpitation, poor exercise tolerance, joint pain, musculoskeletal, mental, depression, anxiety, or comorbid conditions. So BMI and waist circumference are fundamental but not sufficient alone to distinguish the benign pathological obesity. Hybrid approach is optional, and that is, it is feasible, low cost, and adoptable. And this particular screening of BMI and waist circumference should be a part of the classification, assess the symptoms and comorbidities, and classify it accordingly. Why this matters for Indian population is that Indians develop significant obesity and metabolic risk at a lower BMI, and BMI alone will not be able to define the associated comorbidities. So staged based obesity have the clinical implication. Revised guidelines are seem to be more applicable for our country. Incorporation of the comorbidities will certainly have its impact on the clinical approach to the patient, and we can certainly go for early preventive intervention for the stage 1. So we have the opportunity and challenges here, more accurate for our population. It can be standardized more aggressively, and it can be helpful for the healthcare system to follow this. What we need is making people aware of this, public health implications, and early preventive measures and policy decisions need to be incorporating these lines. Future research is focus areas should be examined. Studies should now examine morbidity, mortality trends through this staging method, and intervention effects should be seen, and enhancing guidelines applicability towards more evidences. So carry home message from this is there is a substantial burden of obesity across Southeast Asians. South Asian population manifests a distinct obesity phenotype. There's a unique pattern of adipose tissue distribution in our population, and implementation of the ethnic specific diagnostic threshold of BMI more than 23, waist circumference more than 19 centimeter for men and more than 80 centimeter for women, or body fat percentage of 25.5 for men and 38, more than 38% for women, is fundamental for the accurate clinical assessment of the risk. Recently established obesity guidelines for South Asian population introduces an innovative two-stage classification system that gives you BMI, that transcends from the traditional BMI-centric approach by incorporating functional impairment and comorbidities. So these guidelines seem to be more comprehensive and having therapeutic strategies recommending the lifestyle modification for stage 1 and pharmacolotherapy for stage 2. So your step 1 to measure, step 2 will be to classify, step 3 to treat, and step 4 for follow-up. With this, I stop here. Thank you very much for patience listening.
Thank you, Dr. Shunil. Wonderful presentation, comprehensive and precise.
Thank you very much, sir. I stop sharing the slides, so we have some questions. Yeah.
Great. Thank you, sir, for elaborating on the Indian guidelines so well. I have one question. How do they compare with the ESO guidelines and all the other guidelines in the world? And what do you think is really relevant for Asian Indians?
So these are
always a matter of debate.
Yeah, I feel this is not the time that we have some comparative data on these lines, because if you see the futuristic way, we have to consolidate these guidelines in our population. We have to have a comparison. We have to have outcome data. We have to intervention data, and then only we'll be able to really say. But then when you go through the logic of considering central obesity or the abdominal visceral fat into consideration of the classification, certainly it will have its more clinical implication and beneficial effect on the cardiometabolic risk profile of obesity and other comorbidities. So it becomes more sensible to approach the patient as a whole rather than just with BMI. So you have to, I feel in future, certainly it's going to be eye-opener for us when the data again comes through on these lines.
Yeah. May I ask a question?
Please, ma'am.
Congratulations. That was a very, very wonderful, and it's absolutely recent data.
Yes,
hot out of the oven. No, at the end of the day, as of now, we're still using BMI and waist circumference. But when we talk of, like in the last slide, you said percentage body fat. What would you recommend as a relatively easy to do practical percentage body fat percentage measurement?
Madam, we now, most of the people, they are now using the bioimpedance as one of the method now. I don't think we are going for DEXA or MRI or CT for measurement of the visceral fat for common population, but central obesity, simply measuring the waist circumference could be one of the best way of going ahead on these lines. And of course, if you have, that's why they have given option: waist circumference, waist to height ratio, or the body fat. So even one of them is sufficient enough to classify it as centrally obese.
So routinely, I think that is good enough. What you're saying, the machines that we're using.
Yes,
but only for research purposes, then you would need DEXA or MRI or whichever.
Yes, ma'am.
That is more for research purposes than anything else.
Yes, ma'am.
Thank you.
Thank you.
I think it's a good one. I think for primary care physician, the simple thing will be very good.
Yes.
That is the main important thing. The way obesity has become an epidemic, we need care from primary physicians. It is a very important issue. I think this will make it easy for them. But I'm going back to that. I think I could not take discussion in this thing, triglyceridemia. That was also a very good discussion. I think in diabetic patient also, diabetic patient also got a lot of hypertriglyceridemia. And fenofibrate, these are all right, but we know that they are not effective that much. But I think insulin is very, very important. And insulin is another point for insulin, that insulin should be used. Many times without hypertriglyceridemia also we get very high triglyceridemia. And in those cases, I think because it activates lipoprotein lipase, so insulin is another indication for those cases. And nowadays, thing has become, we are underutilizing insulin. And this is one of the cases, one of the place, I think, where insulin, I think, will be very much indicated.
Sir, there is another issue of I'm going away from my topic and going again to
Yeah.
hypertriglyceridemia, which Sarita madam also I'll love to have her comment on this. We have also have a data on postprandial hypertriglyceridemia.
Yeah.
Traditionally, we see postprandial hyperglycemia at 2 hours or maybe 70 minutes, 90 minutes, 2 hours, whatever data you have in normal population. But when it comes to postprandial hypertriglyceridemia, the peak comes at 4 hours, not at 2 hours. So postprandial hyperglycemia is very classically seen in people with type 2 diabetes, and that need to be addressed more aggressively. But unfortunately, I want to have again, we have Dr. Sain also with us. So maybe this is one of the entity which is existing but is not being properly explored. But postprandial hypertriglyceridemia, we have documented two things. One is that 4 hours it goes to the peak. In non-diabetic person, it comes back to normal by 7 hours or 6 to 7 or maximum 8 hours. But in diabetic population, it remains there up to more for more time, and it doesn't touch the baseline. So there is a more resident time of hypertriglyceridemia in type 2 diabetes versus non-diabetics. So we have three groups. We have normal, pre-diabetes, and diabetes, and pre-diabetes exactly behaving in between. But diabetic population, they have first is postprandial hypertriglyceridemia is 4 hours, which is seen in all of them. But then the resident time is very high in type 2 diabetes. Your comment, Dr. Sain and Dr. Madam.
Right. So that's a very correct observation. And I believe if you actually were able to measure lipoprotein lipase with it, would actually see that it would also fluctuate. And actually, in as we mentioned before, in diabetes patients, so this is like a syndrome complex, right? First hypertriglyceridemia, followed by metabolic syndrome, followed by prediabetes, followed by diabetes, right? This is like an iceberg phenomena. By the time you have diabetes, all the other things have actually happened, including endothelial dysfunction, which is probably right after hypertriglyceridemia. So this increased prevalence of hypertriglyceride in the circulation essentially means that it has not been able to be metabolized, which means the lipoprotein lipase is missing. Lipoprotein lipase to triglyceride is almost like insulin to glucose. And I agree with Dr. Bhattacharya that insulin is the crux of triglyceride lowering, which I also mentioned that is a standard treatment for triglyceride emergencies, no doubt. It's just that on a chronic basis, a lot of our patients don't want to go on triglyceride, and insulin alone may not be enough. That's when you need the other adjuvant therapies. But both these observations are amazing. And if you can get a lipoprotein lipase values with it, it's like doing a glucose tolerance test, right? You measure glucose with insulin. Similarly, you should measure triglyceride with lipoprotein lipase.
Yeah, so those observations are very good. Thank you. Thank you for your input as well. But like when the patients with diabetes come in at the first time of presentations, we find triglycerides 500, 600, really high triglycerides. And we know that with diabetes control, quite often they also have MAFLD, MASLD associated. And we know that with the lifestyle and with lifestyle alone, given because they're just newly diagnosed. So we don't, what you are suggesting is ideally even at that time, even if there's not marked hyperglycemia, insulin would help in lowering the triglycerides. Or we could give a trial of at least, I know above 400, the risk of pancreatitis goes up. But is it justified to continue lifestyle for at least a month or two and see if it makes a difference?
I mean, lifestyle is great. We all know who are real life practitioners that lifestyle does not work. And that's why we have this epidemic and pandemic right now. It's really a pandemic. In the United States right now, 1 out of 3 patients are pre-diabetic. That means they have gone to a stage beyond metabolic syndrome. I don't know the data for the prediabetes prevalence in India, but this is frightening. We need to implement whatever we are doing, whatever we are teaching, way better. Otherwise, we are going to have another issue.
I'm only talking of patients who are coming to us at the time of first presentation. Everything is deranged at that time.
Correct.
We have to rule out the alcohol, we have to rule out smoking, we have to rule out MASLD. So once I would still give them a little time for newly diagnosed. The ones who are well established, if they have hypertriglyceridemia of this order, absolutely, absolutely. I agree that insulin is the answer there. Thank you. Thank you.
I'm not sure. I'm not really sure. But then, how much is the prevalence of this familial hyperchylomicronemia? What you have shown
So familial
people seen so
hyperchylomicronemia.
often in our practice. Yeah.
Right. So the issue is it's not that common, luckily. It's a genetic disorder, so it's a lipoprotein lipase defect or ApoC2 defect and so on. Your presenting triglyceride would be in 800s sometimes. And these are the patients who keep coming back in a yo-yo situation to the hospital and to you with history of pancreatitis. Most of the patients that have diagnosed with FCS, unfortunately, already had a pancreatitis, which means those patients are definitely pre-diabetic, if not diabetic, just because of insulinopenia. You just don't have enough insulin producing cells anymore. So it's unfortunate, but the incidence is lower, but it's not that uncommon either. So, it's a question of, as I tell my fellows, please do suspect it in high triglyceride values in more than 885, which is what the National Lipid Association guidelines would say, that if you have that level persistently and never below 180, those are the patients that are supposedly FCS, even without genetic testing.
In our
Are there
part of India,
subsets of populations that are prone to this?
Come again?
Are there any populations or ethnicities also that are prone to this?
Right. So the populations unfortunately goes back to the same population who are lipoprotein lipase deficient. So I keep on harping on the same enzyme because it's almost very well set at this point that that is the key enzyme that helps to break down not only triglyceride, but if you look at the cascade, every lipoprotein, even the ones that liver manufactures, for example, the first one being VLDL, which is a very big molecule, right? It's chopped down by lipoprotein lipase. It's like a chopper. It's chopped down from VLDL to IDL to LDL, right? And then so if a lipoprotein lipase is missing, all these components remain high. So
in our part of
So when we
India,
used to,
Northeast India, it is not rare. I won't say common, but it is not rare.
Right.
You can't bring down the triglyceride level below 300. Very difficult. So
Yes.
I think I won't say it is common, but it's not rare at all.
Thank you so much. I just couldn't leave, but I really need to leave now. It's 10:30. My
when I
clinic
used
has
to work
already
in
started.
University of Texas, Sabia, we used to get patients all the time with very high triglycerides, especially on the holidays and up
Right.
to the 8,000, 9,000 tunes. And
Right.
our mode of treatment used to be we would start them on insulin drip, They were
Yes.
not diabetic.
Correct.
So we would certainly start them on insulin drip and at the same time give dextrose if needed. So therefore, that was, as he rightly pointed out, insulin was the treatment. And, lo and behold, 24 hours later, they would drop to as low as 100. Of course, you don't discharge them home on insulin. You would send them home with other triglyceride lowering medications and, go from there and have a close follow up. But yes,
Right.
insulin would acutely and very quickly bring it down in under 24 hours. So insulin
Right.
drips, yeah. So we used to do that. I don't know if the Hispanic population is at risk, but we saw that, every week we would have two or three. So it was that routine for us to treat high triglycerides in
And the
thousands.
Hispanic population is at risk. As you know, MASLD, which is one of my favorite other than other organopathies, is highest in Hispanics as far as US epidemiology is concerned. So Hispanics actually are genetically very similar to Southeast Asians. So, and so the only thing about insulin drip, I used to say to the fellows, or I was told by my mentors, remember GKI, that's glucose, potassium infusion. Do
Yes,
not forget the potassium part.
absolutely.
Because as you give insulin, you need to have, particularly in normoglycemic patients, the potassium transport is very fast and drops very fast.
True.
Anyway, thank you so much. Sorry, Rucha, I don't know whether you're speaking after this, but I'm probably going to miss
I'm
it.
willing to forsake for you anytime. No worries.
Wonderful.
No, we want to hear you,
For all time's
please.
sake,
Got
yeah.
to hear
No, we want to hear you,
Rucha.
Rucha, please. And a case presentation, a case discussion is something that is not
Surely.
missed. Please.
Thank you. I'm going to leave.
Yes,
Bye-bye.
thank you,
Thank you.
Dr. Sen,
Thank
once
you.
again.
Thank you
Thank
so
you.
much.
Bye, Sabia. Take care. Good to see you.
Thank you very much.
Take care, Dr. Sabyasachi. Madam, please do the honors.
Rucha?
Yes, ma'am.
No, it's a real pleasure to welcome Rucha. I admire tremendously, not only for her fitness, and I think she's one of the persons I look up to as far as sports endocrinology is concerned. I'm, s- I'm sure.
Thank you, ma'am. That's a
she'll be-
big honor for me coming from you.
Thank you.
I think,
Thank you
Rucha,
for
this
being.
needs to be added onto your CV. It's
I
not
know.
there, but
I'll
this
actually
needs
change
to
my
be
CV
added.
slide. It's so boring with the MD medicine and MD. We should just now write what we feel like, what we do much more passionately. I agree. Yes. Yeah.
So, can we
So
have
I
your
think,
case presentation, please?
yeah. So I think in the interest of time, I'll try to keep it short because we have already overshot our time.
Don't
So
worry
you can
about
see
the
my
time.
screen.
Please go ahead.
Are you able to see my screen?
Not yet. Let's start. Yes. The
Okay,
screen
great.
is
Okay.
there, but. Mhm.
All right.
Yes,
Okay,
that's
great.
yeah.
So what we'll do is we'll try to go through 2 or 3 cases. I picked 3 cases, and I took a mishmash of obesity guidelines we've been using for the Indian scenario. Because even though we have Dr. Anup Mishra's recent paper that has come out, I believe they are not yet being accepted as official guideline. It'll take some time for the pendulum to change, where we are no longer BMI centric. We also know the Lancet Commission recently put out, preclinical versus clinical obesity, and still that is not the norm everywhere. So, welcoming you all again to the Aero webinar. What we do know, however, that all over the world, obesity management now is being looked upon as a primary treatment goal for treating diabetes. And therefore, it's time to reframe the conversation and understand how we can also use this. We are all aware even of this ACE algorithm, and as you can see, lifestyle therapy is at the top of all of this. So, top of all of this is, as I call it, the 5 pillars. That doesn't matter when you're trying to apply what you just learned about triglycerides. You heard Dr. Sabia also say that lifestyle is important, but we all fail. Doesn't mean we stop promoting it. And I am a big believer in lifestyle, and I think what works is the power of digital technology and keeping your patients in the loop. So, nutrition, maintaining optimal weight, physical activity, ensuring good sleep, stress reduction through behavioral support, and de addiction. So, smoking and alcohol cessation would be those 5 pillars that you want to make sure for any of the cases I show you are being already taken into consideration. Now, Dr. Makkar and colleagues and Dr. Neeta Deshpande, some of the audience who's here with us today, some of our mentors, had recently put together this suggestion again for the Indian scenario that these may be the steps, and I thought this was a nice little guideline for some of you who are listening, for the audience, that step 1 is, of course, you're going to do an anthropometric evaluation, not just BMI but other parameters, the waist circumference, waist to height ratio. Step 2, you're going to do the clinical testing. As you just heard how important it's not to become just BMI centric, but understand if there are reasons for obesity or complications stemming from this obesity or consequences, as we like to call it. And then you will go ahead and risk stratify them based on the BMI and based on other parameters. Now, what we are also aware of is the Edmonton obesity staging system, which is not very unlike what you also just saw in Dr. Mishra's classification, where he talks about the medical, the mechanical, and the mental consequences of your BMI being more than 23. And very interestingly, the same waist circumference cutoffs are also included in most of our guidelines. And then, of course, once you have lifestyle modifications, we are then going to also use effective pharmacotherapy and metabolic surgery, bariatric surgery as indicated. So I think most of us are familiar with this EOSS. So I won't spend time on this. And this is again what Dr. Sunil Gupta sir just showed you, that the newer guideline just simply calls it as a stage 1 versus a stage 2 obesity. It's sad to a lot of us were shocked because now BMI 23 and you're stage 1 obese, even if you have no complications. So we are probably not completely getting away from BMI as yet, is what I would like to say. Now, here is what Dr. Sarita Bajaj ma'am also asked, that the body fat proposed in this paper, if you can see up top, it says, mandatory criteria is BMI more than 23. And the optional measures for that stage 1 is the waist circumference, etc. Of course, you're going to do it. But I think the second half is very nice to look at, where it says the body fat percentage for men more than 25% and women more than 38%. And again, the waist circumference for men 90 centimeters or more and women 80 centimeters. And the waist to height ratio more than 0.5, which is kind of standardized. So this is what we could kind of use in the next few cases. Just to tell you what happens when a typical patient comes to you and why we are discussing this. So whenever a 28-year-old, this is a 28-year-old guy, his BMI was 38 per kilogram per meter square, because he read online he should calculate that. He wanted to lose weight. Of course, he doesn't want to spend too much. So what do the patients typically do? They first will try on their own. They'll get a Fitbit. They'll maybe nowadays find some diet on ChatGPT. They'll download some free app and use the free version. I'm guilty. I've used MyFitnessPal free for years. I've never once paid for this app. Intermittent fasting, is that the magic bullet? He read he should try that. Before he will sign up for a program and actually decide to spend money on lifestyle changes, he will go through all of this maybe for a couple of years, lose weight, regain, be on a yo-yo. And therefore, to get away from this is what I want the listeners to understand, that how do you go about it and how do you make your patient succeed? And I think you could have a 4-step approach. Is number 1 is, why has the client come to see you? Why does he want to lose weight? And therefore appropriate goal setting, because very often we are seeing patients with BMIs in great amounts of weight, that is 30 to 40 kilograms excess body weight. What treatment will they be willing to adopt? Understanding that obesity now comes with medications, exercise, diet, and then please remember that choosing lifestyle is a behavior modification. So we need to at the same time start working and telling them from day 1 that what you do today needs to become a behavior change later on, and that would constitute the complete prescription. So when the patient asks you, what should I eat, what works, let it be known it's simply not hypocaloric diet, because that's only going to work for some time, maybe for a month. The minute you will lower calories, what happens? Your metabolism slows down, and then the next time they eat, they regain fat. So several principles of dietary prescription have to be applied. Calorie restriction followed by macronutrient manipulation. So increasing carbohydrates, decreasing carbohydrates, maintaining protein, high fat, low fat, making sure fiber is there, and a correction in eating behavior, because that is probably what it all boils down to. So that's what we like to do in our practice, make sure we are doing all of this for our patients. So with that in mind, let's look at our case number 1. Here's a 29-year-old female patient. Her height is 165 centimeters, weight was 122 kilograms, and her BMI calculated 45 kilogram per meter square. So we all can agree that definitely she is, morbidly obese. She has back pain. She has irregular cycles and has been diagnosed with polycystic ovarian syndrome. Now, she also has a family history of type 2 diabetes. So she has mechanical, she also had some issues with the kind of clothing, self-esteem. So what we need to ask each time, Is this patient obese? So certainly she is. We can do a staging. Does she need evaluation for secondary factors for weight gain? Why has she come to see you? And in accordance with that, what treatment will you offer? So I've just taken a screenshot from the guidelines that these are the steps you would follow, doing all the anthropometrics, including a body fat composition. Then we also do a clinical evaluation, lab testing for comorbidities and impacts, risk stratification, and then management, and most importantly, a close monitoring and follow up. So what we understood from this patient that the reason she wanted to lose weight is she had the highest fear of developing type 2 diabetes. So this is where goal setting comes in. We all know from the graph, which I was hoping one of the previous speakers would show, so I didn't include that slide, is that when we lose 5% body weight, we can prevent pre-hypertension and pre-diabetes. When we lose about 10% body weight, we can prevent again worsening of fatty liver, worsening of diabetes, prediabetes, dyslipidemia. In order to treat HFpEF, osteoarthritis, back pain, you need to lose to the tune of 15 to 20%. She wants to prevent diabetes. So we want to at least make sure we are ensuring in the immediate future, her goal setting would be about 10%, which is about 12 kilograms in 3 to 4 months. So that's exactly what we did. And you can see over here, this patient, when she comes to see us, even though her fasting sugar is completely normal at 90 and her HbA1c is 5.1, her fasting plasma insulin was 25.8, which was high. As Dr. Sabia pointed out, and we all spoke about this insulin resistance leading to a high triglyceride and a low HDL cholesterol. She also, if you look over here on the body composition, she has a body fat percentage of 52.9 and a visceral fat level of 20%. So that is where we can see that she meets, of course, all the criteria. She was certainly enrolled in an intensive dietary program, and she was also started on metformin for her PCOS. If you look at the bottom of the body composition history, you can see that within the first 3 months itself, she was able to go down from 123 kilograms to 110 kilograms. Now, bear in mind that was not the end of the journey because we also did add in, sorry, it's not advancing. Okay, for some reason, it's not advancing. Okay, there we go. So we were able to then continue after she lost in the first 3 months about 10 to 12 kg, she did stagnate. So we were able to at that time also introduce a GLP-1 agonist at the time, which was not the newer molecules. We had some of the older molecules. And she went on to go down to 103 kilograms and with further weight loss, even down to 82 kilograms by the end of the year. And you can see the change in dressing, the change in, her self-confidence, insulin resistance getting better, a lot of things improving, was able to enroll her even in a walking program. And she has gone on to do a couple of 5 kilometer races as well. So the points to make out here is most importantly, I feel, is understand the patient, set tiny goals, and then we can go from, where you want to be using what. So now in the second case, I'm going to ask the audience or the mentors on board to help and tell me what we should do with her. So here we have a 42-year-old female with a history of hypothyroidism for about 8 years. She has a history of gestational diabetes. And when she came to see us, she has already undergone one, stenting, which was followed by a bypass. And she has gone on over time. She says she has gained about 30 kilograms of weight in her, lifespan in 14 years gradually. Her height was 150 centimeters and her current weight is 81.2 kilograms and her BMI is 36.1. So if we can just for the next 3-4 minutes discuss, and I can open it up to all of our faculty members as to, what would we like to do for her. So we always do a very detailed lifestyle recall. I'm just showing a little bit of over here that as you can see, this is what we eat in Gujarat. We like our khakra and mamra or kurmara, as you might understand, in the morning. Then we love our roti, sabzi, dal, chawal. Again, for dinner, we love our muthias, theplas, and poha. And as you can see from the evaluation down there, what we eat is a very high carb diet. So I don't know, Sarita Bajaj ma'am or Purvi, whoever wants to chime in. I don't want to pick on anybody, of course. That how should we approach this? Because now she has, and what is the reason we are trying to lose weight? The cardiologist sent her to us. Okay. So what I'll do is I'll just go through it. So we do the same steps again. Is she obese? So we do the staging. Naturally, we know the BMI is more than 23. Now it has become very simple. We don't need to remember the BMI. In the previous case, yeah, so do we need evaluation for Cushing's or something else? We always do check for thyroid as a part of our panel. Cortisol or Cushing syndrome is not something we check for routinely because it's not that common. If there is any suggestion or they fail to lose the weight, then we may look for it. In this patient's weight, we need to lose a higher amount of weight. Goal setting has to be done to prevent HFpEF from getting worse. Of course, on her 2D echo, she had HFpEF, which is heart failure with preserved ejection fraction, and the target becomes almost 15 to 20%. In today's scenario, the minute somebody with diabetes has underlying coronary artery disease, you certainly want to also offer them a GLP-1 analog right off the bat. And the guidelines also suggest that. However, since we have a huge lifestyle program in our clinic, we did do a diet intervention that we went from 200 grams of carbs to 150 to 160 grams of carbs. We taught her carbohydrate counting, and what we found that the easiest thing for her to do was to replace her lunch because she loved her breakfast, she loved her dinner, but she was willing to have lots of vegetables and a buttermilk and everything at lunch every day, which tremendously helped her to improve her diabetes and everything also. And as we can see over here, that within 3 months, she was able to initially lose 10% body weight. She continues her work with us, and this was simply without even using GLP-1 because there was some resistance from the family. We have further used GLP-1 in her, and she's been doing really well and keeps following up with us. All right. I'll just do this last case and then we can stop over here. So 56-year-old male patient, as you can see, his height is 176, weight is 106.9. He presents to us with a slow weight gain with type 2 diabetes, lack of energy, blood pressure, and skin pigmentation. And I'm sure all of you will guess what the skin pigmentation is. The questions again we ask ourselves, does he need evaluation and what treatments will you offer him? So this is what we were able to, he was eating a lot of, if you will believe it, processed food, chips, sodas. He traveled, so he would eat on flights, he would eat wherever he was in restaurants. And we made it a point that he needs to clean up his act. And he was able to have a lot of interesting food art items made at home. And similarly, he's decided that for breakfast every day, he would just use a meal replacer. And meal replacers do come in handy. And as you can see, in 3 months, I mean, he had remarkable transformation from almost 117 to 90 kilograms. Again, he's somebody with diabetes, so using a GLP-1 agent is not off the charts. You can use that certainly for him. His body fat went down, visceral fat went down, and you can clearly see over here the body composition history. You can see how he continues his journey with us. And I would say from almost close to 5 to 6 months only, 107 kilograms to 86.5. Muscle loss is very minimal, whereas the fat loss is from 42 kilograms to 28 kilograms, if you can see over here. And therefore, you always expect with any lifestyle or any intervention, some amount of muscle loss also. You just have to make sure it's not in a significant amount. And you can see this also his acanthosis, that is the skin finding on his face. It gets way better as soon as he loses the weight. So I believe this is the last case, and I'll stop right over here and we can have a few minutes for discussion. So I'll hand it back to Purvi and I'll stop sharing if someone has any queries. We can sort of stop right there. Yeah. All right. I think Purvi has also had to leave, so it's only three of us. So, ma'am, I'll hand
He's
it to
in a
you.
car, so ma'am,
Yes.
you'll take up.
Sure.
I didn't want to step on her toes or anything like that. I just thought if she's around, it's just us. No, so actually, this is very, very nice. I really enjoyed all the three cases. But what I love most is like people who follow lifestyle will have faith in lifestyle, isn't it? So what you
Yes,
emphasize is
absolutely.
lifestyle
No, I think
is the
lifestyle is nice when it works, but then I think the harder part is after they are done with the weight loss program, to sustain it, Yeah.
that I think all data has shown across board that it is the most difficult to sustain. But you see,
Mhm.
irrespective of whether you go in for pharmacotherapy or bariatric surgery, it's lifelong. Even
Absolutely.
after you
Yes.
stop we know when we stop the GLP-1 analogs, then there is not entire weight rebound, but you would tend to regain some of it. So even with
Correct.
bariatric surgery, you may regain you when the metabolic problems come back again, and lifelong monitoring is required. So it is a disease. It is really a serious disease, isn't it? Whatever you may say.
Yes, absolutely. So we see that also with the lifestyle changes.
Yeah.
The minute they go away, when they come back, 3 months later, they've regained at least some of the weight. So I'm not saying that, we managed to keep it off. So now we've actually come up with a maintenance plan wherein they get at least a monthly check-in with the dietitian. If they've gained, then my dietitian will immediately give them a 10-day plan. Okay, let's do this, some diet for 10 days and be accountable. And that really seems to do better. We are sending them, if they stay in the program, we send them WhatsApp reminders, something small like, hey, one small change, go for a 20-minute walk. Did you take, remember to take your fiber, like some small changes that they could do every day. So they get a daily message. That seems to work. But yes, if they are not accountable, so human beings' behavior change, very difficult. Yes.
So the two things we miss in our country across board in most places would be for a diabetes a nurse educator or diabetes educator, whatever you want to call it, and a nutritionist, really qualified, not just ye khana, ye khana, ye khana, ye khana, need to be able to understand the patient's requirement based
Correct.
on their job profile. Like you said, this person, like he's eating wherever on the flight he's eating, and the restaurant he's eating. So what happens there? So there's somebody, if somebody has to understand, counsel, and not just counsel,
Absolutely.
every visit needs to be, so this behavioral modification. So we miss the proper counseling, number one, and behavioral modification. I don't think, do you have a psychiatrist or psychologist or psychotherapist on board whom also you send patients to sometimes?
So for the first patient, she had to closely work with with our counselor,
Okay.
because she told us right off the bat that she has a lot of self-esteem issues and everything.
Mhm.
So we just suggest, but also you have to suggest it very gently, because in India it's still a taboo sometimes. So yeah.
That's true. That's true. So it's
So
a
lifestyle modification does work. Not that in many people it does work. The point is
Absolutely,
that
sir.
the person must understand that. The one point is that we must make it simple. For diet, I make a thing, and it is pretty effective in our part. We are fish eater, we are meat eater. So I first say you take the protein-rich food. Fish, very common in our place. Egg. Lean meat, probably local chicken. Think you can take it. Then you go for vegetable only, except potato. You can take everything. And then you will touch your rice ball. And that works. I think
Absolutely, yes.
it is almost like age limit. People cannot take carbohydrate. And in diabetes, and I think they think I think they take a lot of independence there in my food, so it works. I think that's
Absolutely,
why
sir. Yeah.
Osama Hamdi. I think Osama Hamdi. I always salute him. He's a great man. Really works. If you give a list and too many things to do, then it becomes difficult. But this works.
step by step. I agree. Thank you.
Yeah.
Thank you very much.
Right.
So it's been a
Well,
great meeting and nice to
yes,
meet
thank
you,
you
of
so much.
course, Rucha and Bikash.
Yeah.
That's
Yes,
the
yes,
pleasure of
lovely.
it. That's the pleasure
And
of it.
thank you
Wonderful.
for all the delegates for
Good.
staying with
Good.
us for so late. So I think we'll close the
Thank
meeting here,
you. And to
and
the
we can
digital,
stop recording also
to
to
the
RX
digital
events.
team for their
Yeah.
support.
Thank
Thank
you.
you. Thank you. Good
Thank
night.
Thank you. Good night, everyone. Take
Yeah.
care. Good night. Yeah.
Bye.
Good night. Good night.
अरे हो गया क्या?
Yes, ma'am.